online on MMWR. And what it showed is that a 2-dose vaccine series, especially that series that has been given over 6 months prior, is not nearly as effective as somebody who's had a boosted vaccine series. And so in the urgent care, ED urgent care, a 2-dose vaccine series given 6 months prior had a vaccine effectiveness of approximately 38%. That went up to over 80% if you've received a 3-dose series or a boosted series. When you look at hospitalizations, what we saw is that a 2-dose vaccine series given 6 months prior had a 50% vaccine effectiveness in preventing hospitalizations, which went up to 90% if you were boosted. And so this is the first evidence coming out of the United States that really shows the significant impact that booster doses has on vaccine effectiveness for Omicron. Very different case for Delta. We're not seeing Delta anymore. So right now, really the story here is that a boosted vaccine series is quite protective in preventing ED urgent care visits and also hospitalizations from COVID-19.
Okay, let's go through that again. I think that's really important, some of the data points. Again, so the takeaway message from this study of looks like almost over 222,000 encounters from 383 hospital emergency departments and urgent care clinics across 10 states and 259 hospitals. It also included nearly 88,000 hospitalizations among adults aged 18 and older from August 26, 2021 to January 5th, 2022. The takeaway message from the findings, what would you say, how would you summarize that?
Booster doses, people that have been boosted, have a vaccine boosted series are much more protective against hospitalizations and ED visits than those that have just received a 2-dose series.
Okay, and how much of a protection, how much of a benefit were the booster doses did you find in the study?
Yeah, so if you look at those individuals that were boosted, they had a 90% reduction in hospitalization. And if you look at ED urgent care visits, they had over an 80% reduction in ED urgent care visits compared to an unvaccinated population. And then if you compare that to a 2-dose series, it was significantly greater than if you were boosted.
So what's the important message that you would take away as a physician to the community, to the lay public in terms of these findings and then what they mean, the implications for the public moving forward?
Yeah, the implications really for us mean that if you want to be fully up to date on your COVID vaccination, you need to get a booster dose 5 months after your second shot. That booster dose in the setting of Omicron is much more protective against ED urgent care visits and hospitalizations than just that 2-dose series. Omicron is a different virus. It has mutated to the point where the protection that we have with the 2-dose series just isn't enough to prevent ED urgent care visits and hospitalizations. You really need that 3rd dose, really to increase those neutralization antibodies to be able to protect yourself from really severe disease. Really, that's the take-home message for us.
And I saw in the analysis of the study that it's termed real life. Why is that important? And why is it important that it includes Omicron data, not just simply Delta? It really covers periods where Delta was the predominant variant and then Omicron was the predominant variant.
Yeah, these studies, you have to be nimble with the research coming out now because you really have to be able to assess the effectiveness of vaccines during a time period where we have a different variant circulating. Right now, less than 10% is going to be Delta. And so the vast majority of our population is being infected with Omicron. And the effectiveness of these vaccines against Delta versus against Omicron are different. They're different variants. And so we really have to be cognizant of how well these vaccines protect us now with the current circulating variant.
This is a huge study, and kind of tell us what the Utah link is here. We had Utah patients as well as Intermountain researchers. You were heavily involved. How did that come to be, and why is that important that our Utah patients and perspectives are being included in these national research studies on these vaccines?
Right. It's important for us to do these studies, throughout Intermountain Healthcare and throughout Utah because, these are Utah patients. These are data that is coming from our communities that we can then reflect back to our public to educate them to understand that, yeah, this isn't just a national study coming from other states. These are data that are coming from Utah. These are our communities that are addressing these questions. And so then we can give good, accurate data on vaccine effectiveness to our communities at large here in Utah. Intermountain is one of approximately 7 networks that are included in this network of networks. And we contribute a large amount of data because of our large footprint across the state of Utah. And because of that, we can inform, local policy and also national policy with some of the data that we're able to contribute.
We'll get to some of the questions in the chat briefly, but tell us what it means in terms of the progression of the doses. And so again, we have a number of people who have had 1 dose. We've had a number of people who are completely unvaccinated. We have people who had 2 doses and yet not the booster. So from these findings of this large study, what does it tell us from 0 to fully boosted? How would you summarize that in terms of coverage and protection from these vaccines?
Right. So being unvaccinated is the highest risk. You don't have any reduction, obviously, if you're unvaccinated. Being given 2 doses of the vaccine series, so 2 doses of either Pfizer or Moderna, offers you some protection against ED and urgent care visits and hospitalizations. But if you then receive a 3rd dose, at least 5 months after that second dose of the series is recommended by the CDC, that gives you the most protection at preventing ED urgent care visits and hospitalizations. What this study is unable to do is take into account prior infection. That's an important piece that is very challenging for us to put into analyses like this, especially now with the advent of home antigen tests. We just don't have the data in terms of prior infection to say, what does that contribute to protection? It likely has some level of protection. It's probably additive in addition to your vaccines, but it's just not data that we have access to that we can put into studies like this. And so these studies does not take into account prior infection. It just takes into account vaccination records. And so certainly a 2-dose series is somewhat protective, but a boosted series is even more protective and is really what we should be striving for.
How important is getting this current data in our current climate in terms of maybe somebody still on the fence about whether or not to be vaccinated? Now that you have this newest, latest data that does include the impact on Omicron, what would you say to those folks who are still on the fence?
Yeah, it's actually incredibly timely data because if you go out and you get your booster shot, that booster shot will give you immediate benefit within 5 to 7 days. As opposed to starting a vaccine series where you get 1 shot and then a month later you get another shot and you really don't start seeing that benefit until 2 weeks after that second shot. The benefits that come with a booster comes very, very quickly. And so we are in the midst of our Omicron surge. Cases have never been higher. We have not seen case volumes like this. And if you go out and get boosted, you'll have very significant protection as we go through this Omicron surge. So it's incredibly timely that this is coming out now. And hopefully it encourages some people to go out and get that boosted shot, because we know there's plenty of people that have received their 2-dose vaccine series but have not received their booster.
A question from Jamie Lampros at the Standard Examiner up in Northern Utah. And I think this question is one that many people may have. She says, if the vaccinations are working so well, why are so many people who are vaccinated becoming sick with Omicron?
Right. So great question. In the time of Omicron, vaccinations are definitely what we call attenuating disease. So keep in mind, we're looking at visits that are ED urgent care visits. So you have to be sick enough to come to the emergency department or the urgent care, or you have to be sick enough to come into the hospital. And so what our study is showing is that is what the booster and vaccination is preventing, those attended medical visits. It's not saying anything about all infections, just the symptomatic person that's recovering at home. We don't have any analyses against that at this point. And so what this is showing is that vaccination, particularly boosted, is really reducing the severity of disease so they don't have to come to the ED urgent care or to the hospital. Now, we know that people that have been vaccinated and those that have been fully boosted can still get Omicron. They can get symptomatic Omicron, and the vast majority of those people do well at home. They don't need to seek care. They don't need to come to the ED. They don't need to come to urgent care or get hospitalized. And so what this is showing us is that, vaccinations reduce severity of illness. But you're absolutely right in the fact that if you've been boosted, you can still get Omicron infection. It's going to be a much milder illness. And it's also important to recognize that you can still transmit that infection to somebody else.
Really, the study looked at utilization of hospital resources, medical resources, and then also severity. And so talk about that, because right now in Utah, we are at a record level of hospitalizations. We are seeing high volumes in the emergency departments at hospitals across the state, at urgent care centers. Talk a little bit about that impact and connection between utilizing these resources that are in scarce supply right now with this protection.
Yeah, they sure are. One of the challenges we've had here in Utah is that we never came down from our Delta surge. And so our hospitals have been over that 85% capacity in the ICU since mid-August. We never really came down from that Delta surge, and then we had Omicron hit. And so it was hitting at a time when our ICUs were at 95, 96, 90%, 97% capacity, and that's when Omicron hit. And now we're seeing case counts that we've never seen before. And in addition, we're seeing our hospitalizations numbers continue to rise. You can see that's reflected on the state Utah Department of Health website with hospitalizations rising in the past 10 days. That's happening here in Intermountain Medical Center and Intermountain Healthcare as we speak. This weekend, we're having to open up 20 new beds at Intermountain Medical Center. We're having to open up 14 new beds at Riverton. And this is just to accommodate the number of patients that we're seeing in our hospitals that are coming in diagnosed with COVID-19. So it's incredibly timely. If we can reduce hospitalizations, we can decrease that burden on our hospitals, and we can ensure that care is available for everybody who needs it, whether or not you have COVID or not.
Question from Lisa Riley Roche about the future implications from the data. And she asked, what does this study suggest about the need for additional booster shots? I don't know if there's anything that leads to additional insight there, but what do you think?
Yeah, Lisa, it's a good question. We don't have the answer to that. We're looking at data that was, approximately 15 or 20 days worth of Omicron transmission. We needed to get this data out quickly. We do not have enough data here in the U.S. to say what is the effectiveness of booster in terms of time since boosting. The effect of a booster is likely going to wane, just like the 2-dose series is. But we don't have data on that in this report. That data will come as we get more and more infections and endpoints in our data set to be able to assess that. But right now, we're unable to assess how well the boosters do over time to see the effect of waning.
A combined question from Jacob Ruda at KSL News Radio, along with Jamie Lampros from the Standard Examiner. When speaking of, have Delta cases disappeared, or are they simply not as prevalent as Omicron? And then a follow-up from Jamie, how long will the boosters, do we anticipate, protect people? Do we have a sense?
Yeah, so the first question, looking at the state data, the state sequencing data, is that we are well over 95% Omicron. What that remaining 5% is unclear. I suspect that's remaining Delta cases, but those haven't necessarily been sequenced to my understanding. If we look within Intermountain Healthcare and we look at the platform called Thermo Fisher, that's a PCR platform that we can use to identify COVID. And there's certain signatures in that result that give us a hint to things being Omicron. And within our data set, well over 90% of our isolates on that Thermo Fisher platform are Omicron as well. And so the vast majority is Omicron. And that's what we're seeing nationally too. If you look at CDC data and other regional data, Omicron has fully outcompeted Delta and any other variant that was circulating, and is now by far the predominant variant in our in Utah and across the U.S. In terms of how long, in terms of a prediction, the data out of the UK definitely can give us a little hint to that, in the fact that a booster dose does wane out to approximately 4 or 5 months, but we don't have definitive data here in the US. We anticipate that there is waning, and whether or not that has implications of another dose or a dose prior to next season's respiratory season. All that is speculation and yet to be told. All depends on what happens post-Omicron.
A question from Erin Alberti from the Salt Lake Tribune. She says, can you remind us what the recommendation is for timing of the booster? Should people who get vaxxed for the first time today immediately go for 3 shots in a row, or do they need to get the 2 shots or 1 for J&J and then wait a certain amount of time for their booster? What's that interval and frequency?
Yeah, CDC recommends to wait 5 months after your second dose if you received an mRNA vaccination series. And that's still the recommendation at this point. They have not changed that recommendation in the setting of Omicron that I'm aware of. J&J was not included in this study. We do not have any estimates on J&J. As you know, the boosting interval for J&J is much shorter, but we do not have any data for J&J in terms of the effectiveness against Omicron, given the fact that there just aren't as many people that received the J&J vaccine to allow us to do those calculations.
Okay, follow-up question from Lisa Riley Roche. How did age factor into the study results that we're talking about today?
Yeah, so you can dig into the study a bit and see the impact of age. Booster still has a great impact on those folks that are greater than 65 years of age or greater. This is consistent with data that's coming out of the UK as well to show that a boosted vaccine series prevents hospitalizations in the age 65 and plus.
Okay, and a question from our audience on Facebook, some folks asking about natural immunity again, and a question about vaccine immunity versus natural immunity. What do we know about that, and what impact does this booster study tell us about that, if anything?
So this study doesn't tell us really anything about natural immunity because we're unable to bring in prior infection data into an analysis like this for the reasons we stated earlier. What we do know about natural immunity in the setting of Omicron is that prior infection with Delta or the ancestral strain or Alpha has very little impact on your risk of infection with Omicron. And so there's been some studies out of California and out of Houston that shows that you are 5 times more likely to have had a prior positive test in those that have been infected with Omicron compared to those with Delta. And so prior infection with Delta, Alpha, or the ancestral strain really does not provide much protection against getting infected with Omicron. Whether or not it has an attenuation of severe disease, unclear, because we're unable to do those studies right now, given the time interval. So those that have been infected with Delta, even those that have been recently infected with Delta, they're still at risk for Omicron. But whether or not that prior infection is going to protect you from a severe disease is unclear. It just shows you how different Omicron is compared to Delta, and that those antibodies that were formed against Delta don't cross-react that well with those those that would be needed for Omicron.
There's been some discussion about Omicron kind of being the final phase of this pandemic, that this is. What are your thoughts on that? Is there going to be the next Omicron variant, the next variant to Omicron?
There's definitely going to be another variant. I mean, that's what viruses do, especially if we see worldwide circulation, there will absolutely be another variant. To what extent prior infection with Omicron is going to cover the next variant is unclear. If Omicron provides broad neutralizing coverage against Delta and other prior strains, that could be a very good thing in terms of us moving forward and having less COVID in our lives. Studies that are looking at the antibody response from Omicron and coverage against prior strains is ongoing, and it looks promising. But it really is going to be dependent on what does that antibody response, what does that T cell response look like from Omicron, and how well is that protective against prior variants and prior strains. I sure hope that the immune response that we've generated from Omicron is going to be protective. That would be ideal. And that our community immunity that we've generated from vaccination and infection will be robust enough to prevent these really significant surges that causes hospitalization numbers to go up. That's best case scenario. And there's plenty of people who think that that will be the case. And so we're really going to have to see what happens, particularly with an eye to UK, to South Africa and other European countries that are going through this now, to see what their post-Omicron phase looks like as they are, months ahead of us.
There seems to be a bit of an attitude about this inevitability of getting Omicron because it is so common versus just getting it and getting it over with versus prevention. And we're seeing that in masking use rates. We're seeing that in vaccination rates. As a infectious diseases specialist, what's your perspective and feedback on that?
Yeah, the question you're asking, Jess, is why do I not want to get this now? Why not just get it over with and kind of move on with their lives? Omicron does cause a milder illness, and we're definitely seeing that bore out here in Utah as well. And that has, data that's coming from the rest of the U.S. as well. However, it's not a mild illness for everyone. And I think that's what we need to keep in mind. There's plenty of people that are being hospitalized. There's plenty of people that are in the ICU. There's still plenty of people dying from COVID-19. And so I think the biggest issue that we need to focus on is how do we protect our vulnerable population? Yes, you as an individual may not have severe disease, especially if you've been vaccinated and boosted, but you can still transmit that disease. You can still transmit the infection to somebody who is very vulnerable, somebody who is older, somebody who has immunocompromised, somebody who's an organ transplant patient. There's so much in the community right now. And there's so many vulnerable patients that are getting infected that come into our hospitals. And so besides the fact that this is not a pleasant illness to go through, we don't want to have this if you don't have to have it. It's really how do we protect our vulnerable populations? Those are the people that are ending up in our hospitals. In addition, we have so many people being infected and we have so little medication that is effective in the outpatient setting. And so only one of the 3 monoclonal antibodies actually work against Omicron. We have one drug called Paxlovid that is effective against Omicron, but our supply of those drugs are so low. And the reason for that is that the entire US is going through a surge right now. And so that drug supply has to go throughout the entire United States. And we have a very small allocation of those drugs that the state is saving for the people that need it the most. And so we really want to protect that vulnerable population to make sure that they don't get infected. And if they do get infected, that there's enough medication for them to prevent severe illness. And so it's really our focus should be on how do we protect those in the community that are the most vulnerable. In addition, this is having incredible impacts on hospital staffing and other economies. Schools are having to go back to virtual, daycares are shutting down because of positive cases. It's hard to find employees to work, and it has incredible impact on our economy. So if we can minimize that, keep people uninfected and move past this Omicron surge, it'll be better for the economy. It'll be better for the health of our communities as well.
Yeah, yesterday the Department of Health reported record hospitalizations in Utah, 756 patients hospitalized across the state, which is the highest it's been in the pandemic. I know in the Intermountain system, there was over 520 patients hospitalized of that 756. So a significant portion in Intermountain hospitals. So follow-up question from Aaron Alberti. You mentioned 34 new beds opening up this weekend at Intermountain facilities to deal with the high volume. How does that go with staffing? Because we know that 34 beds are not going to take care of people. How's the staffing going to support that 34 additional beds?
It's an incredible challenge. We are asking more and more of our staffing every day. Our hospitalist doctors, our nurses, our respiratory technicians, our pharmacists, our EVS workers, we're asking more and more of them every day to help exactly what you talk about, staff those beds. Beds don't care for people, people care for people. And so we need physicians, we need advanced practice practitioners. We need nurses to be able to add these beds. It's something that we have to do, take care for our community. But it's an incredible challenge to do that.
Okay. Follow-up question from Lisa Riley Roche at the Desert News. Is Intermountain Healthcare seeing increased demand for COVID-19 testing that does, and this, with the state recommending that most Utahns now skip testing, what is the impact? And then also, what is the impact of lower case counts have in our understanding and really our full grasp of how much it's spread within the state?
Yeah, a lot to unpack there. So let's start with the recommendation to not test if you have symptomatic disease. That is definitely the case for people that are young and healthy. And so if you're young and healthy and you have symptoms that are consistent with Omicron, COVID-19, general upper respiratory infection, sore throat, sniffles, cough, etc., that's Omicron until proven otherwise. And if you don't have access to a rapid antigen test, you can just assume at this point that that is most likely Omicron. The people that need to be tested, the people that absolutely need to be tested, especially early in their symptoms, are those that are vulnerable to severe disease, those that are at high risk for having a bad outcome, such as hospitalization, ICU, or death. Those are people that are older. Those are people that have chronic medical conditions. Those are people that are immunosuppressed based on medications they're taking. If they have an organ transplant, those people absolutely need to be tested and need to be tested early in their symptom onset to see if they are eligible for some of those therapies that could keep them out of the hospital, that could prevent them from dying. And so if young and healthy and don't have access to a home antigen test and you've got symptomatic upper respiratory infection, symptomatic therapies at home, isolate from your family and friends so you don't spread the illness to somebody who could be more vulnerable. But those that are at high risk for complications, particularly hospitalizations or severe disease, absolutely need to get tested to see whether or not you would be a candidate for one of our medications that could potentially be life-saving. Testing is a challenge right now. It's a challenge everywhere. And I think what we'll see is that it's going to be hard for us to use our case counts to determine when exactly we're up and over the peak. We've hit essentially testing saturation in the state of Utah, where we just don't have any more tests to be able to do. And so that may certainly blunt how high our case counts go, just because we're not able to test enough. And so until our case counts start going down, and until we start seeing hospitalizations decline, until we start seeing our test positivity decline, those will be the true indicators of when we're actually up and over the Omicron hump.
If following up on that, some clarification or understanding, there seems to be a lot of confusion amongst the public. When do I go to the emergency department? When do I go to urgent care? When do I go to my doctor? Is there anything that you can add to help clarify that understanding? Again, it's very personal, depending on your symptoms and your risk, but what would you say to that? Because there does seem to be, the emergency departments are full, urgent care clinics are full. How would you address that?
Yeah, I mean, I think obviously if you have severe shortness of breath, if you have severe cough, if you are not doing well at home, you need to be seen by a clinician. Whether it be in the ED or the urgent care or your primary care office. If you're having pretty severe symptoms, especially if you're having shortness of breath, by all means, come and see us. ED, urgent care, Connect Care, your primary care doc, you need to be seen by a clinician. If you have mild symptoms, and especially if you are young and healthy, or you don't have any underlying comorbidities and you've been vaccinated, that's something where you can ride that out at home, take Tylenol for fever and pain, and just track your symptoms. Now, if you have medical complexity, if you're older, if you're not vaccinated, if you have underlying health conditions, immunosuppression, incredibly important to get tested. You don't necessarily need to see a physician for that, but you need to get tested and let your care team know if you're positive, because they are going to be able to then refer you on for therapy. If you're also in that high risk group and you have significant symptoms and you can't get a test and you need to be evaluated, by all means, come into the urgent care or the ED to be evaluated. And so really, if we're going to change therapy, if we're going to get you on medications, you need to let your provider know of your positive test. You need to come in and see us to get that test done and get evaluated.
And you've seen the emergency departments and urgent care clinics. What would you say about expectations? Because volume is very, very high right now across hospitals across the state.
Be patient with us. Our volumes are incredibly high. Be kind to our caregivers and just be patient because our volumes are incredibly high. And, one thing that people don't really kind of think through is that our medical surgical wards are at 99% capacity. Okay, so we are at max capacity on our medical surgical floors. That's why we're opening up these beds at IMC and Riverton. That has implications. So that means that a patient that's in the ICU that's ready to come out of the ICU doesn't have a place to go because our beds are full. That means that a patient in the emergency department that needs to be admitted to the hospital to one of those beds doesn't have a bed to go to, so they stay in the emergency department and tie up beds and rooms in the emergency department. And so the increased volumes in our hospital has this trickle-down effect in terms of affecting ED wait times, ICU volume because patients can't get out of the ICU. And so it becomes a very complex challenge in terms of managing patient transfer and flow in our hospital when our floors are that busy, and that backs up into ED wait times. And so be patient. Our caregivers have been through a lot. They're doing the best we can, but absolutely come in to seek care if you need it.
Okay, we're going to wrap up here, but we have a question from Facebook, one of our viewers there who's asking about what do we know about long COVID and Omicron? Because we've heard that it's more mild, but are we seeing, and perhaps it's too soon in the current environment that we haven't had that time to determine whether or not there's lasting implications for Omicron infection. Do we know anything about that?
We know very little about long COVID after Omicron primary infection. That's going to come with time. Omicron really, hit Utah hard right around the holidays, December 25th. And so we're going to know much more about symptomatic long COVID in the next weeks to months to follow. But right now it's just too early to say.
Okay, we're going to wrap up. We appreciate your time, Dr. Stinian. Thank you so much for joining us, and thanks for all you're doing. Thanks for everybody who joined with us. I know we weren't able to get every question, but we've run out of time. We will provide a copy of this briefing. We'll also provide a link to the study and a copy of the study that has been published this morning regarding vaccine effectiveness with both Delta and Omicron. And we will be holding an update next week to provide both further updates as we go. So thank you so much for joining us. Thank you for our folks who joined us on Facebook. We appreciate your time. Please be safe, mask up, be vaccinated, and please be well. And we'll see you next time. Thanks very much.